Hello everyone. Yes, I'm
Hello.
audible.
Yes, you are audible.
Okay. Good evening, ma'am. Good evening, sir.
Good evening.
Good evening.
Yes, sir. We'll start the
Yes,
session
morning
within 1
for
to 2
me.
minutes.
All right, so we can start, I think.
Yeah.
All right.
Okay.
Okay, so yes.
Should I start?
Yes,
Okay.
yes.
So,
Yes.
good evening, everyone. Myself, Raghav, and on behalf of Global Association of Indian Medical Student and International Relation Council, I welcome you to this vital discussion. GAIMS is a premier platform dedicated to empowering Indian medical students globally, fostering a community of future physicians who lead in research and advocacy. Operating within this framework, the IRC, International Relations Council, are bridge to global medical community for international exchange and academic dialogue. Under the IRC, we have created SRISOG, Sexual and Reproductive Health Education Society of GAIMS. SRISOG ensure equipped with multidisciplinary insight into the uses of reproductive health and maternal care. Today's session, the rise in incidence of PCOD and stress-related menstrual disorder, is a perfect example of that mission. While PCOD is often viewed through a metabolic lens, we are here to explore its deep-rooted psychological dimension also. By bringing together experts from both psychiatry and gynecology, we aim to bridge the gap between the endocrine health and mental well-being, addressing PCOD as a complex whole body condition. Without further ado, I hand over the floor to our moderator Girik to begin our expert panel discussion. So Girik, start.
Hi, am I audible?
Yes, you are audible.
Perfect. So, good evening, everyone, and a very warm welcome to today's session by Games IRC. So, before we dive in, let me just take a moment to set up the stage and just let you guys know what are we going to discuss tonight. So, PCOD or the polycystic ovarian disease is, in fact, no longer gynecological diagnosis, and I think it lies in a very minute intersection between what we can say it is a hormonal, a behavioral, and in fact also psychiatric condition. Chronic stress often dysregulates the HPA axis, which would, let's say, elevate the cortisol levels and would disrupt the delicate hormonal balance as well. So, in fact, I was going through his research and it also mentioned a line like which was very apt and which stood in my mind that brain and body are not a separate system. And in fact, in younger study, this connection is actually playing out in many ways. So tonight's conversation is exactly about that. So I'm Girik and I'll be your moderator for today. Before starting, just let me lay down certain ground rules for the smooth conduction of the event. So please, participants, please keep your mic on mute until and unless prompted to do so. Guys, you can lay down your questions in the chat box, and I'll select the best ones for the Q&A round at the end after the panel discussion. And even though it's not mandatory, I request everyone personally to keep the cameras on so as to make this much more interactive and please keep the chat professional. For the panelist, the each of the presentations will be approximately 8 to 10 minutes, and after all presentations, we will move into a structured panel discussion and then followed by a Q&A round. So, without further ado, let allow me to introduce our very first speaker, Dr. Tazeen Ashraf. She holds an MBBS, FCPS, FA MR MRCPI card, and COD qualifications. And in fact, that is a testament to career built across multiple healthcare and geographies. She is also the director of Study Medic Pakistan, vice president of ICC EBCOG Europe, and was also named among the 200 women power leaders of 24-25. Ma'am, to be honest, this is where I came across it, like where I came across your recognitions. This was where like I could say that you are truly making an impact in the field. Like this is on a very personal note.
Thank you.
Guys,
Thank you.
please welcome Dr. Tazeen Ashraf.
All right. Thank you so much. Thank you so much, Global Association of Indian Medical Students, and thank you so much, Girik and Raghav. Actually, when I came across your invitation to participate, that was something which was very motivating for me as well. I have been associated with this mentorship and teaching as well from the last 6 years. So, coming across all medical aspirants, having sessions with people who are doing their fellowships and memberships, and then doing my clinical practice, actually it gives you, a lot of clinical experience, how these things basically you face in the real life. And that was actually exciting for me as well to share with you guys that how we can help the medical students as well as other people about PCOS. And actually the idea that by combining this PCOS with psychiatric problem, that was actually very impressive. We are all the times we are trying to manage the gynecological aspect most of the time, but we are not taking care of that psychological impact which it is actually having, that should be treated. And if we are not actually treating the root cause, then that is very problematic, that we are just medically trying to tackle it. So thank you so much for inviting me, and that is actually a big moment for me as well to share my knowledge with all of you. And once again, I'm very thankful to you. So I would like to share my presentation with all of you. We will quickly go through that what PCOS is, and then we can take the questions as well by the end. All right. Okay, so basically, we are going to talk about PCOS in young girls. That is actually something which needs early recognition, which needs early diagnosis, as most of the times we are missing the diagnosis in most of the cases. And when the patient or the woman or girls, they present with us in later stages of life, then it is something which has some implications as well. So how we can go about, as all of you know, Girik has actually given you the intro. I am Dr. Tazeen Ashraf. I am practicing as obstetrician, gynecologist, and fertility expert at Evercare Hospital, Lahore, which is actually a group of hospitals. They were the hospitals in India as well, care hospitals. So that is a chain of hospitals. Evercare is basically associated with them, and I have been practicing as consultant from the last 3 years with Evercare. So meanwhile, I completed my memberships and fellowships. I was also inspired by a lot of Indian fellows and also my seniors from Pakistan. So that's why that was the aim, that you just have to keep growing. So I just kept on doing these things after my fellowship from Pakistan. So why PCOS is important? Thank you so much actually for selecting such a good topic which needs discussion, as it is very common. Most of the times in our gynecological OPDs, we are seeing such patients who are coming to us, and it is said that now 1 in 10 girls basically they present with these symptoms. And its impact is very long term. When we see about the patients, it has long term implications. We just face the young girls when they are coming to us with the menstrual irregularity, that they are having scanty periods are absent for 3-4 months, or irregular periods are there. But at times there are certain other implications of PCOS are as well, with which they are not coming to gynecologists specifically, that they are having acne, hirsutism is there, facial hair growth is there, body hair growth is there. And these days basically weight changes and weight shifts, they are also very very important, that weight gain is there, but they are much worried about their menstrual irregularity. Along with that, basically what happens when all these changes are happening, definitely anxiety is there, depression is there. And someone actually having acne, and when they are having as alopecia is there, weight gain is there, cycles are irregular. So that is actually affecting their mental health. And what actually we face in clinical life is that their topmost priority when the patient or the young girls they are coming to us, that is menstrual irregularity. Then they are much worried about that the acne is there, hirsutism is there, weight changes also. Yes, weight changes are happening. And mental health is the most neglected part, that how it is actually affecting their quality of life. And this is associated with metabolic problems. So long-term implications of PCOS are always ignored, that cardiovascular problems are there. Endometrial hyperplasia can lead to endometrial cancers. And then insulin resistance is there, which can lead to development of diabetes. I always tell to my PCOS patient that every birthday you have to check your glycosylated hemoglobin. So this is your birthday gift that you have to follow in that way. So that is basically the implications which we come across in the long term. Basically, there are three main clinical features. As I told, that the first one is menstrual irregularity. The second one is acne hirsutism. That is basically due to excess androgens. There can be clinical hyperandrogenism, or there can be biochemical, that when you get the hormonal levels, you find out that, okay, yes, hyperandrogenism is there. And scan is basically not diagnostic, but we go for scan after the clinical history and after seeing the patient. 25 to 30% is the sensitivity of scan ultrasonography for PCOS, and that shows you peripheral follicles, size of follicles is less, ovarian stroma is higher, ovarian volume is higher, and we can find out that yes, this is actually leading to this complication. And a very famous Rotterdam criteria is basically being used for PCOS, that menstrual irregularity would be there. There can be scanty periods, then clinical or biochemical hyperandrogenism. Few patients, they might not be at the initial stages, they might not be presenting with the clinical features, that acne hirsutism, but biochemical hyperandrogenism can also be there. So both things, they can be correlated. And then ultrasound evidence of PCOS, that 12 or more follicles are peripherally ranged, which we say that pearl string sign is there. Then ovarian stroma is more than 10 ml. So then we are able to reach the diagnosis that, okay, this can be polycystic ovarian syndrome. But the diagnostic challenge in young girls is basically just they start having their cycles. Basically, there is hypothalamic immaturity. And in the first 1 and 2 years, their cycles are irregular physiologically. So that is basically challenging at that moment, that how you have to label the patient, like just immediately after starting their menstrual cycle, when they are having menstrual cycles and they are facing, these are puberty symptoms as well, like acne and can be there. So they are having certain changes in the body. Their cycles can be scanty or irregular cycle due to hypothalamic immaturity, they are there. And then at times, when they are coming to us, so we have to be very cautious that how we have to diagnose PCOS. So in the first 1 and 2 years, we cannot say that this is polycystic ovarian syndrome. We have to follow them. Follicles are immature at the beginning, cycle irregularity is there, acne hirsutism is there. Then with time, you are able to diagnose that, okay, these changes now, they are not due to hypothalamic immaturity, and this can be PCOS. Along with that, you correlate with lifestyle as well. Along with that, you correlate with their weight gain and other changes as well. So what actually happens in PCOS, this is not just a gynecological problem, as I mentioned earlier as well. This is basically a group of problems which actually is missed, that we are just worrying about the cycle irregularity or subfertility or what is happening. Metabolic problems and psychological impact is missed in most of the cases. Insulin resistance is there. So insulin resistance is basically higher insulin levels are there. So if they are not treated well, in the long run, that will lead to diabetes, development of diabetes. That's why we are so concerned that we say that these patients, they should take care of their glycosylated hemoglobin levels on annual basis. Hyperandrogenemia is there. Irregular ovulation, so irregularity of ovulation, that is leading to cycle irregularity, as well as when these patients in the long run, when they can have subfertility issues as well. So that irregularity of ovulation is also problem. So all these basically, they are a group of symptoms, and when all these symptoms are there, so definitely they are leading to anxiety, sleep deprivation can be there, stressed life can be there, or as in all medical graduates or post medical graduates, in doctors life stress never ends. So that can be a problem for all. So these are basically a group of symptoms which is happening. And among these, the most commonly I have seen the patients who are coming to us either with menstrual irregularity or with subfertility. Like they are not coming to us with other problems, but other problems we correlate and we find out that, okay, these changes are also there. We have already discussed that as well. So diagnostic difficulty, as I mentioned earlier, that irregular periods are actually expected post-menarche as well. Then acne can be physiological as well. And lifestyle changes and weight gains. Few people, most of the times, they correlated that weight gain is in my family. So in my family, everyone is obese. So that might not be associated with that. So we have to be very cautious when we are actually diagnosing, and this is basically a diagnostic challenge in adolescents as well. And complications, they are short-term complications at the moment which they are facing, like poor body image, emotional distress, and they are having the symptoms which are there. So all these, they are affecting their academic life as well as social impact. And in the long run, subfertility, type 2 diabetes, hypertension, endometrial hyperplasia can lead to endometrial cancers, cardiovascular disease, and obesity. These are the long-term implications of PCOS which are actually happening. So what we actually do when the patient is coming to us, the first thing is always the clinical evaluation or the information from the patient, which all you get, and you reach actually by talking with the patient that what actually is the problem which is happening with them. Then we go for further testing as well. Hormonal blood tests can be carried out. Always it is very important to rule out thyroid as well, as thyroid can also it is hypothyroidism that leads to anovulation. Menstrual problems can also be there. Hyperprolactinemia you should rule out. And we find out basically testosterone levels are higher, so which will give a clue that, okay, hyperandrogenemia is there. Ultrasonography, 20 to 30% cases, it can give us an idea that, okay, this can be PCOS. And then we can go for other clinical measures like height to weight ratio is raised, waist circumference is higher, and all these things basically clinically we correlate to reach the diagnosis. When a patient is coming to us, or when an adolescent or young girls they come to us, actually it is in their mind somehow that now this doctor is going to give me a long prescription. And pharmacological treatments, it is expected when you talk with the patient, and when you start a talk with the patient that your problem basically, the ultimate treatment of your problem is that you have to change your lifestyle. The patient actually, they give you an impression that they are set aback by the doctor's opinion that you have to change your lifestyle. But that is the root cause of this PCOS, that lifestyle is basically very, very important. Once their weight reduction is 5%, I have seen in my clinical practice over the time that PCOS symptoms, they start reversing. So balanced diet, regular exercise, sleep, appropriate sleep times, they are very, very important. And everyone is so busy that they say that I can do, crash diets I can go for, but balanced diet is a problem for me. I can't go for fancy diets. I can't find time for, workouts or anything. And I can't sleep on time. So all these things, basically the ultimate thing, which is that we can go for pharmacological treatments, we can manage the symptoms, but what to do when the root cause is not treated? So the root cause is lifestyle and followed by pharmacological managements, which we can see that if the patient is coming to us with menstrual irregularity, we can regulate their menstrual cycle. If they are coming to us with subfertility, we can treat for subfertility, that we can go for ovulation inductions. But what about that lifestyle which is needed? If I'm going to give some ovulation induction with obesity, then I will face that pregnancy with a lot of complications as well. If hyperandrogenemia and height to weight ratio is not coming back within the normal range, then I will regulate the menstrual cycle for 3 cycles, for 6 cycles, by giving the oral contraceptive pills or what. But the root cause is not treated, then how to go about? So basically the mainstay of treatment, we must say, that is lifestyle. And every young girl, they should adopt that is the thing which they should take care, that they should move more. Exercise and workouts, that should be a part of routine life. Healthy eating is very, very important. Sleeping well is a question for gynecologists especially, and for medical graduates especially, but still we can try to manage that. At least we are not web surfing, Netflix and all these social medias. They can be stopped at some time, that we are able to get appropriate sleep, and we have to manage the things appropriately. And if anxiety is there, if stress is there, you feel that you are not feeling well mentally, then there is no harm to talk with someone. There is no harm to seek counseling. There is no harm that you should receive the counseling session, so that all these things, they can be treated appropriately and they can be managed. So basically the psychological impact of PCOS, that is very important to be managed to treat the physiological symptoms or other symptoms of PCOS. Okay, so there might be some other problems. We are trying to, advise the patient that you have to bring down your weight, but they are having some eating disorders. And if that root cause is not treated, how we will be able to, get that? So all these things, they are important. Basically, PCOS doesn't mean that it is subfertility, but it leads to subfertility when ovulation is not there or cycles are irregular. That is the in subfertility practice, you face a lot of patients with PCOS who are having ovulatory issues. So that is a long term, after young age, that is the thing which the young girls have to face if the things are not taken care. So yes, it is common, 1 in 10 girls that is facing, but lifestyle is the cornerstone. Instead of thinking that I have to go for pharmacological management, yes, they are the tools which help us, but lifestyle is the cornerstone. And the other things, that other aspects, metabolic aspects, psychological impact, they should be taken care, instead of just treating the irregular cycles, just treating the subfertility. That is a group of symptoms, and it is treated as a group of symptoms, and it should be a multidisciplinary team, that they should be connected with some exercise or dietitian. They should be connected with a counselor if they need, they have a lot of anxiety and stress. They should have psychological counseling sessions and treatments. And then we may involve endocrinologist as well if the hormonal imbalance is not treated, and then gynecologist, they can treat their problems of menstrual irregularity and subfertility as well. So we have to actually, as we all the doctors, we always say that we have to treat a patient, okay, not the disease. So that is basically the mainstay, that we have to handle, and we have to tackle all their symptoms and all those disturbances which are happening in the body, instead of just one problem which they feel that this is the problem, but there are certain interlinked problems as well which we have to take care. And if those are not treated, then definitely after some time there would be recurrence, or they would be presenting with the same problem, and you won't be a good doctor in their files. So that is the thing, that if you have to take care, then you have to take care the whole patient, the patient as a whole, that what all problems are there. And I have seen in my clinical practice that we are very reluctant to involve other specialties as well. We want to treat each and everything on our own, but no, we should be very generous to involve others so that this can be treated appropriately. And that is the thing which we can do for these PCOS. So that was all from my side. So if there are any questions, we can have questions, or if we have to take the questions by the end, we can take by the end as well.
Ma'am, we will be taking the questions at the end, like
Yes,
after
sure.
the panel discussion.
All right. Okay. Thank you
S-
so much.
so thank you, Dr. Ashra. That was truly an enriching one. And next we have Dr. Akshay Prabhu. Dr. Akshay holds MS in OBG, FMES qualifications, and is a gynecologist and a laparoscopic surgeon. He is also the managing director of Akshay Hospitals, overseeing 15 plus hospitals across the three districts in the state of Kerala. In fact, he has also pioneered laparoscopic training programs for doctors. So I can literally say he is preparing the next generation of laparoscopic surgeons. So over to you, Dr. Akshay. The floor is yours.
Thank you so much, Greg.
Thanks, sir.
Yeah, so just a small correction. Actually, I don't own 15 hospitals in Kerala. I own a hospital and I operate at 15 hospitals. I'm a visiting surgeon at 15 places. So
Oh, I'm so sorry, sir.
That's okay. I'm purely a gynec laparoscopic surgeon. And first and foremost, thank you to GAIMS for inviting me here to be a part of this panel discussion. Even though PCOS is not my area of expertise because I'm primarily a surgeon, but still it always gives me a lot of, what do you say, happiness to interact with youngsters, to share some of my wisdom and experience with you people. So because you are taking the medical profession forward. So thank you so much for having me here. And a big thank you to Dr. Tazeen. She has done a wonderful job of actually making the entire PCOS into a capsule, telling you about the causes, pathophysiology, the treatment aspect, everything. She has reduced our job, in short, at least my job. So we'll just take the discussion forward from what she has said because she has covered almost everything. So just wanted to share a personal note, a personal advice is that when I had chosen to do gynecology back in 2010, one of my criteria was that it is an end specialty. So once I do my MS in OBGY, that's it, because at that point of time, the MCH or DM was not popular in it and it was not required also. So it was considered an end specialty. But by the time I finished my 2015 MS OBGY, I just started realizing that there is much more to OBGY than just being a general obstetrician and gynecologist that used to work maybe up to 10 years back. My mom is a gynecologist. She has practiced as a general obstetrician and gynecologist for her entire life, handling everything. But by 2015, I'd seen that the scenario had changed. So one entire year, I actually spent just doing fellowships and observerships and whatever possible, just to see what I can focus on or specialize in. And that is how within 2 to 3 years, I finally chose laparoscopy as my niche. And since 2018, I have been only practicing as a gynec laparoscopic surgeon. And last year, I started my training program for junior doctors, for gynecologists in laparoscopy. So what I'm trying to tell you is that earlier, one gynecologist could handle every single thing. But now, I think each and every disease requires a specialist in that field. And PCOS is one such field because you need to spend a lot of time with the patient. As Madam correctly pointed out, it's not the diagnosis you're treating. You have to treat the patient as a whole, not only her pathophysiology, her physical effects, her mental and psychological effects. Everything has to be dealt in detail. At least 1 hour has to be spent with a patient who's suffering from PCOS, bare minimum. And every gynecologist cannot afford that kind of time. And even myself, I don't spend so much time with PCOS just because my wife is a fertility expert and an endocrine specialist in gynecology. So she's running an IVF unit. So I refer my patients to her because it's her niche. She can spend so much time with them. She spends at least 1.5 hours counseling them. It's not only important to counsel the students because these adolescent girls may not understand the counseling fully. You have to counsel the family too. You have to keep the mother will along with her. You have to keep the father along with her because they are going to face a lot of harassment from the school, a lot of harassment from their relatives, neighbors, and everything. So not only her, you have to prepare the entire family for this particular condition. Second thing is that because of the long-term impacts, Madam rightly pointed out, one of it being subfertility, and you know how India fertility issues are viewed. It's a very big social stigma. So again, coming back to the point, it's not just necessary, because a girl who is 13 or 14 years is not going to understand the impact of fertility, is not going to understand the impact of impending diabetes in the future, or going to understand the impact of endometrial carcinoma happening at 40 or 50 years of age. So you have to prepare the entire family, because this is going to be an ongoing process till she maybe attains menopause also. There are going to be wide-ranging effects, long-term effects. So nowadays, every gynecologist, most of them at least, have, what do you say, branched out into micro specialties. Some people are practicing laparoscopy. Even in laparoscopy, there is a super specialization now, endometriosis surgeon specialist. There are people who are only operating endometriosis. Now there are PCOS specialists or endocrine specialists. We have got urogynecologists. We have got gynec oncologist. We have got high risk pregnancy specialists. So what I'm just trying to tell you is that if you're going to this path of gynecology, be very careful, because gynecology is not the end of it. Like I had thought in 2010, times have changed, and each disease is requiring a micro specialization now and a micro specialist. A PCOS patient might get more justice or more care when she goes to Tasneem madam rather than coming to me, because I'm a busy surgeon. My time is spent in OT, operating. So I don't get much time to spend with patients in OPD. But my bypass or solution to that, at least my wife is there, my mother is there. I refer them to them so that they can spend more time with them. In addition, now what has happened is that there is a huge patient gap and a doctor gap also happening. What is the patient gap I'm trying to address is that nowadays, because of the advent of Google and AI models, a lot of people with some set of symptoms are going to search for these diagnoses in AI models, and they're going to get some certain diagnosis. So they have that, what do you say, so stigma, or they have that fixed mentality that, okay, these set of symptoms means this is the diagnosis. They come to you with a diagnosis. Many times they don't even have PCOS. So as madam had rightly pointed out, first 1 year in adolescence, when you start having periods, there is a high chance of HPO axis not attaining maturity, and up to 1 year of irregular periods in absence of any other abnormalities can be considered normal. You just have to treat it. So some people just with 1 or 2 periods, they just go and search in AI, ChatGPT, Claude or somewhere, and they get this diagnosis that it's PCOS, and they come to you with that fixed mindset. And even if you try to convince them that it's not PCOS, you don't need medication, they are many times not convinced. They go around to other doctors, and all doctors are there are every basket of apple has bad apples also. So every doctor is not going to care for that. So some people may even take advantage of it. They may go from modern medicine to alternative routes of medicine also. They may get other treatment. So this gap is also one of the reasons why PCOS, the proper diagnosis of PCOS and its treatment, gets delayed. Now, secondly, the doctor gap is that in many countries, especially India, your time with the patient or the number of patients you see is also directly linked to the revenue. Finally, a doctor has to feed himself or herself also. So to spend 1 hour with a PCOS patient, that PCOS patient is not going to pay you 5 times or 6 times of the consultation fee. The consultation fee she has paid, she's going to utilize for the 1 hour. And especially in Indian scenario, you will get the patient will be there, the parents will be there, the uncle and aunts will be there. Sometimes even the neighbors will also come. And you'll have a huge group in your sitting in your OP counseling them. So that gap has to be. So that's why I say we have to go into micro specialty. We need to involve more specialists. Like you need to have counselors. So what we have done is we have got a dedicated counselor for these PCOS patients and IVF patients. So when you handle the medical part, you have trained the counselor well, so that the counselor can take care of the other mental and the psychological aspects of it. You spend 1 hour with them. You spend one or 2 hours with them. And in case you have more doubts or anything, you're always welcome to come back to clear those doubts. So, and again, reiterating the point, very important point which madam has made, medicine and treatments in PCOS are just an aid for you to get your lifestyle in order. Many people think eating medicines or having those medicines is the end of it. No, they're just because lifestyle modifications are always difficult to make, because it's a matter of willpower. So initially, when they have that hesitation to change, what you give is you give certain medications like metformin or combined oral pills or inositol, so that initially when they see results with these medications, they are motivated more to get into their lifestyle modification. So what ideally plan is that we plan for 3 to 6 months of medication, giving that window period for that the family and the lady to get the lifestyle modification in place, so that you can slowly wean off the medicines after 3 to 6 months. It's not a lifelong prescription of medication like many other diseases. So that's the main purpose of, because it doesn't solve the problem. The only purpose is It helps the patient or the girl to transition from what she is having as a lifestyle to a better lifestyle so that the root cause of PCOS is solved. And finally, one more point I wanted to touch upon, which Madam has just put in one slide, is that a lot of people up to maybe 10 years back, a lot of gynecologists had this generic advice. If you have PCOS, take this medicine. Eat less of carbs, less of fat, more protein, go for a walk every day. 30 minutes of walking daily solves the issue. See, for PCOS patients, there are two types of exercises which is very essential. One is I simply explain as aerobic exercise. Aerobic exercise is anything which you can do at ease for a long time. For example, you can walk for a long time. You can maybe slow swimming for a long time. You can do slow bicycling for a long time. You can do slow jogging for a long time. You can do a treadmill or a cardio for a long time. If you can do 30 minutes of aerobic exercise twice a week, it's good enough. That is called aerobic because you have time to breathe. Oxygen is your main source of energy for the muscles. But again, this aerobic exercises focuses on consumption of calories and fat decrease. So what it happens, it does definitely help in reducing the insulin resistance. But more importantly, what you need is you need strength training exercises or weight bearing exercises. Like, for example, you need to lift weights or you need to do resistance exercises because these are the exercises which are going to build your muscles. And why muscles is important? Because muscles provide receptors for insulin to act. Insulin primarily acts on the muscles to push the glucose in. The GLUT4 receptors are there on the muscle. So unless and until you increase your muscle mass, the insulin resistance is not going to fall. The action of metformin or any other similar drug is to increase the insulin sensitivity. And this equivalent action is done by strength training or gym exercises or weight bearing exercises. The larger your muscle mass, the insulin resistance is going to fall faster. So whenever you advise, don't say just go walk for 30 minutes a day or 60 minutes a day and that is solving the problem. No, that will solve the problem to a small extent. But more importantly, you need to have weight bearing or strength training exercises to have rapid fall in insulin resistance. And this helps you go back into your normal lifestyle. So this is the only thing which I wanted to add on the career advice and what PCOS things which I wanted to highlight. And I would rest my case with that.
Thank you, doctor. Yeah, truly the surgical and the systemic perspective you shared were like really put the things to a perspective from a surgical POV, like which you just mentioned. We'll come back to that also during the time of the panel discussion and the Q&A round. For now, we will be moving forward with our next speaker, Dr. Sai Sneha. She holds an MBBS degree along with a Masters of Public Health with a specialization in epidemiology. She is a sexual and reproductive health advocate, a 2025 Hirsch-Staffel Fellow, and was recognized through the Indiana University's Office of Student Lifestyle Spotlight in 2025. She truly brings the data and the public health conscience to the conversation. A great round of applause for Dr. Sneha, please.
Thank you. Thank you for inviting me. Honestly, it's such a great panel. It's such an honor to be with distinguished panelists. Like they are all professionals and have a really lot experience in this field. I have just started working in this field. I work as the sexual health education coordinator, and my perspective is mostly regarding education and like creating awareness rather than treatment. That's where I come in. There are a lot of points I plan on talking about that Dr. Ashraf and Dr. Prabhu have shared, and it's such an honor to be in the same panel with you guys. Thank you for this opportunity, GAIMS. I haven't imagined I would be in a panel like this at this point of my life. So where I come in, I bring in population perspective and also like public health perspective. And my lens is it doesn't focus on diagnosis and like management. My perspective is more like, why is there a delay in diagnosis? Why is this condition so common? And like, why is it not managed and across populations, like well managed? And what we see consistently at the population level is like delayed diagnosis, especially in adolescents. And there is also like under recognition in like primary care. There is variability in access to like healthcare access to, like depending on where you live in, like we don't have access to healthcare, and also like healthcare literacy. Like not many of the people know about the conditions. They think they have, it's normal, like it's normal to have irregular cycles. Sometimes it's just the stress or like, their lifestyle. And sometimes they don't have awareness about the conditions. And that's where medical students and like doctors come in, educating students um, about all the menstrual health related conditions and gynecological conditions, especially in schools. I think that's where you can start volunteering, uh, as you guys already are doing, like going to schools, talking about all the conditions. That's where students can learn about stuff. Um, Other than that, I haven't prepared like an actual presentation for this. I thought we'll be discussing about different questions. Um, the other stuff I plan on talking about is my current population that I work with is students, where they have like academic pressures and like social identity formation, which all impacts your menstrual health too. And they lack health literacy basically about PCOS, and they don't think much about it. And all the environmental factors and the stress factors actually interact with the young women's body and their lives, and the worsening of symptoms. It's just not biological. It is also like environmental and behavioral, and also shaped by like modern life contexts. And one of the most discussed part, like Dr. Prabhu has mentioned, is stigma. The important issue is stigma, like fertility anxiety, and also like misconceptions and misinformation about, like you see social media and you see a lot of stuff, and like Dr. Prabhu has mentioned, like AI. So they talk to AI, and like they search in social media, they hear a lot of things, and they come to a diagnosis by themselves. And that's where we come in. We actually give actual information and like actual education to the students, or like the people we talk to. We clear those misconceptions and like give like facts about the conditions, and like refer them to specialists, like depending on what the condition is, like refer them to specialists like Dr. Ashraf or like Dr. Prabhu, like depending on the condition. And also there is a lot of silence about menstrual health in our culture too. Like when I was a kid, I wasn't taught a lot about menstrual health except the cycles I have learned, and even in schools, that's what we learn. As medical students too, I think we need to have more education regarding women's health in our medical schools that we don't talk about a lot. All we learn is about anatomy and the physiology and the biochemistry, the basics. But I think as medical students, if we learn more about women's health and the perspectives and like the communication part to like the patients, I think that would reduce a lot of barriers and like stigma that surrounds menstrual health. I guess that's the most of the stuff I plan on talking about. But I guess if you have more questions, I think I could talk specifically about those questions, like, from my perspective. I'm so sorry. Thank you.
No worries, Dr. Sneha. So I think that would be really anchoring our panel discussion after the presentations. So like now we can move on to our next speaker, Dr. Hari Krishna Mamtani. Our next speaker, Dr. Hari Krishna, is a NIMHANS trained neuropsychiatrist holding MD, PDF, and MRC side qualifications. He has done over 30 publications to his name and has also received the Young Investigator Award at WSBF Istanbul in 2024 and hosts the Mental Health with Dr. Mamtani podcast. He is also someone who makes neuroscience accessible truly. This is something which I also like, which is something what tonight's exactly needs and something which aligns with our topic today. Dr. Mamtani, the floor is yours.
Thank you, Girik, for the kind introduction. And I think thank you, GIMS for having me here, and I think congratulations to GIMS because the kind of issue that you've raised this time around. I know it's a series of webinars that you keep on doing, but you chose to do one on the impact of mental health on PCOS. I think which speaks volumes about the kind of thought process that you guys have put in, because I think it's a need of the hour. We always talk of PCOS as an endocrine disorder or a reproductive disorder. But let me tell you, it's no more just that. It is a neuroendocrine disorder. So essentially, when we look at PCOS, I would rather put it as it has three pillars. And I think Dr. Akshay, Dr. Tazeen, and Dr. Sneha have kind of covered those pillars to some extent in their narrative. But let me just emphasize on the third pillar. So the first two pillars are hormones and metabolism, which I think we've kind of understood by now. But there's an equally important role of the brain here, which is the third pillar of the pathophysiology of PCOS. And in my next 5 minutes, 6 minutes of my talk, I'll just try to, uh, you know, um, highlight the importance of the brain part of it, the brain bit of it, the mind aspect of it. Like Dr. Sneha, even I'm not prepared with a presentation as such, but let's hope my message is going to be loud and clear. So, the first thing here is that, we need to understand that the biology that underlies the pathophysiology of PCOS. We mentioned about hyperandrogenism and insulin resistance quite often. Dr. Tazeen and the second speaker also, Dr. Akshay, also mentioned about it very extensively about it. But let me tell you that hyperandrogenism can have mental health underpinnings also. So we know that hyperandrogenism, if so, I know we're all medical students here, so I can use a little bit of technical language here. We know that hyperandrogenism can manifest I mean, simply speaking, behaviorally speaking, more aggression, more irritability. That is something, hyperandrogenism manifests with. So as a psychiatrist, I can tell you that, this is going to be a very common manifestation in, let's say, your patients of PCOD as well. But there is some underlying neurobiology to that as well. It is known to cause serotonin dysregulation. It also, I mean, hyperandrogenism is also known to cause changes in your brain, and it's not just because of serotonin, but also GABA glutamate dysregulation also plays its equally important role in causing these behavioral symptoms. And when we speak of insulin resistance, that's another aspect and another important point, which is the hallmark of PCOS, as has been repeatedly mentioned. And insulin resistance also somehow, I mean, we all know like insulin is involved in glucose metabolism, so somehow the glucose supply to the brain goes for a toss. Very simply speaking, you can understand it like that. So that common symptom of cognitive fatigue or the brain fog that the patients report to us with is somehow related to the insulin resistance. And also goes without saying, insulin resistance also contributes to the dysregulation in the serotonin and the dopamine levels in the brain, which ultimately results in certain mood changes. And one final thing in the biology, apart from the hyperandrogenism and the insulin resistance, is the inflammation. There's also inflammation, which plays a very significant role here. So the inflammation can contribute to, again, a whole lot of changes, but predominantly via the HPA axis. And that can lead to dysregulation in how a person handles stress. So, I mean, just kind of summarizing the last couple of minutes, the biological aspects of PCOD relating, I mean, causing mental health issues can be pinned down to hyperandrogenism and insulin resistance, and also inflammation along with the HPA axis dysregulation. And in psychiatry, we very often speak about the biopsychosocial model, where we suggest that all these psychiatric issues or psychological issues are a manifestation of the biology, of the psychology, and of the sociology. So all these three contribute to cause some mental health symptoms in any individual. And enough has been spoken about the biology about of the mental health issues, but I think it's also important to highlight the social aspects. Dr. Tazeen in her narrative very beautifully covered the body image issues that come with PCOD. So that's something that is very commonly that we see in our practice as well. But alongside that, there's one more aspect to it, that is the stigma. I mean, even Dr. Akshay spoke about how subfertility is associated with stigma in the Indian context. So, just takes me back to one of my discussions with a senior gynecologist here. Dr. Girik had mentioned about the podcast that I do for mental health awareness on YouTube. I had done one podcast on mental health awareness in pregnancy with a very senior gynecologist here in Nagpur, where I'm based. And she shared some of her incidents of how she's seen stigma percolating in the society whenever there is this element of subfertility. And mind you, that kind of stigma is going to be much beyond these serotonins, dopamines, or hyperandrogenism, whatever we talk about. So that definitely has a role to play in the mental health underpinning. So I think this is a very good initiative. Again, to congratulate GAIMS to have this kind of a discussion, so that more and more medical students are made aware of PCOS, but not just of PCOS, but also of the mental health underpinnings of PCOS. And so PCOS can manifest with a range of mental health symptoms. Dr. Tazeen, her slide very rightly mentioned that the chances of depression are almost 2 to 3 times more than what you see in the general population in women with PCOS. And the reasons we've already discussed why. So that's something which is very common. And again, body image issues are very common. Sleep is again a very major contributor to the pathophysiology of PCOS, because that kind of dysregulates the stress, and that in turn contributes to the person not being able to follow the behavioral modifications. So I would rather make a case of this being a bi-directional thing. PCOS and mental health issues, they can be bi-directional, so it's like a vicious cycle. Having PCOS results in mental health issues, but if you have mental health issues, the recovery from PCOS gets even more difficult. Uh, Takes me back to one of my discussions with another gynecologist colleague back when I was there at NIMHANS. So we used to have very frequent referrals shared amongst us, and we used to discuss how women with PCOS who also had depression found it really difficult to, be motivated to follow the treatment changes. To, let's say, to as simple things as just exercising. Forget about exercising for 150 minutes a week. They were not able to find even 15 minutes from the daily schedule because they were just not motivated. That feeling of lack of self-worth or self-esteem, as whatever you may call it, but that was contributing to them not getting better. And once they sought treatment for their depression, they were out of it. The things changed. I mean, their prognosis for PCOS improved. And even when I was doing a little bit of literature search for this presentation today, uh, you probably would not believe, but simple things like mindfulness-based stress reduction therapy. It's a kind of therapy, psychotherapy that psychiatrists and psychologists employ. That had improved the outcomes in PCOD in terms of making the cycles more regular. There are these studies that are consistently showing that if you make these simple changes in your mental health, the outcomes of PCOS improve. So I mean, so at the end of the day, it all boils down to what does it translate to? I mean, the kind of take home that you guys, medical students, would want, my fellow gynecology and fellow public health colleagues would want to take from this is one very important. I think we should be very actively involved in being very open-minded for screening for mental health issues. I really appreciate Dr. Tazeen's initiative of being generous to involve other professionals, because I think that's the need of the hour. The integrated care model is going to be the future. Dr. Akshay already has that in his setup, a counselor. So I think these steps like these are really needed. So if you are very open for, addressing the mental health concerns, that makes a significant impact on the outcome of your patients. And at the end, that's what we are looking at, right? So let's just hope that, you are able to give better outcome to your patients. Let's not treat our patients with PCOS partially, because if we are just addressing the hormones, it's partial treatment in my opinion. We're just trying to holistically help the person, and the outcome changes just like that. On that note, thank you so much once again for your patience listening, and I really look forward to the questions that are going to come up.
Thank you, doctor. The neuropsychiatric point of view actually kind of painted as a perfect picture. I would like to say, like, it created a complete circle, I think. I think
Indeed.
we do have all some of the like I personally also have some questions to ask you. But now I think Dr. Gaurav will not be able to join us today because of some emergency, and Dr. Isha will be joining after some time. So for now, we will be starting with the panel discussion. So let me start by asking one question that Dr. Tazeen mentioned. This is for you, Dr. Tazeen. You mentioned in your slide that 1 in 10 girls of the reproductive age globally are affected by PCOD, and yet this diagnosis is delayed. So, like from your experience, from like across multiple areas, like in the Asian population, or in fact in the European healthcare system as well, like, do you think are we still missing this? Why are we missing this so consistently?
Thank you so much, Girik, for the question. Basically, as we discussed, basically PCOS presentation is not just, with typical symptoms. It presents in a variety of symptoms, and that is the reason that the diagnosis at times is missed, that there can be metabolic problems, there can be gynecological problems, there can be psychological impact, or there can be the patient is presenting with obesity and other things, and that is the reason that this diagnosis might be delayed in some of the cases, as the presentation of the patient is in various ways. So that is what which is challenging, and how we find it difficult to diagnose. But still it is diagnosed and it is treated, but the root cause should be treated. I must say that instead of just going for one or two symptoms and then the job is done.
Dr. Akshay, what's your perspective on this?
Just a minute, just a minute.
Sure.
Sorry for that. Just had an emergency call. Okay, so see, I agree to see basically compared adolescent PCS more often than not may not have classical symptoms. That is one of the reasons why it may not be detected early. Secondly, again in that age group, people may not approach a gynecologist primarily for those issues. They may approach somebody else. They may even approach a general practitioner, may approach a physician, may approach an endocrinologist, and they may come that round way, finally reaching up to the gynecologist saying that there could be a PCOS. So there again is a delay there. Then, as I said earlier, patient gap and doctor gap. Sometimes patients may have a fixed mindset of diagnosing something early and having a fixed mindset on that. Secondly, a doctor gap where doctor may not have so much time to diagnose or diagnose in detail what it requires. So adolescent PCOS ideally requires more delicate handling, more extensive analysis and counseling compared to somebody who's developing PCOS at a later stage. That could be one of the reasons why the diagnosis gets delayed. And secondly, even as we had discussed so much about the stigma part, so nobody wants to get branded as a PCO because, as I said, the stigma associated with the fertility and the other problems which come later. So that might also prompt a delay in diagnosis or seeking proper treatment.
So, like as you mentioned, you are also operating in around 15 plus hospitals in the state of Kerala. So, when a young woman walks into one of your facility or one of your clinic, like with let's say regular cycles, so like what actually happens? Like, what would be the real pathway that you would be following, or like as you mentioned, your mom or your wife would be following in that case?
See, every case of irregular cycle is not PCOS. So as Dr. Tazeen had pointed out in a slide, first we have to rule out all other causes. We have to rule out the endocrine causes. We have to see which year of her menses is she in, when has she attained menarche, which year of her menses is in, has her HPO axis matured enough, and then rule out the other causes. And once all other causes are ruled out, then you go into the diagnosis of PCOS, where you apply the criteria. Criteria has to be slightly more stricter compared to the older PCOS, But that is how you stepwise, because a lot of times what happens, endocrine causes of these irregular cycles are missed, which are more common in younger adolescent age group. So we generally steer the process to a diagnosis of exclusion.
I think I was going through a study. I think that was in the Journal of Clinical Epidemiology. I think it was a 2023 study. So I think that found in that it was stating that the average time for this onset of the symptoms in PCOD diagnosis is like over 2 years in the South Asian population. So like it really raised a question in my mind, and I think this is the exact platform that I would like to research on. Like, why is it, what is happening in that gap, like from a clinical or an epidemiological point of view? Like, Dr. Sneha, would you like to weigh in on this?
Yeah, thank you. Yes, I think very much so. What you told is true. The data consistently supports that delayed diagnosis is like a major and like an actual issue across South Asia, and also like many places globally too, not just South Asia. And the gap is really due to not just like a single factor, it can be like multiple factors like systemic failures, not just from the patient, but also like as a healthcare system too. Firstly, symptoms differ in different people. Like not everyone presents with the same symptoms. There are many early symptoms like irregular cycles and like acne, like weight gain, like Dr. Rishabh mentioned in her presentation. Those are all like normalized by patients and families, like as part of stress or like as part of adolescence. We don't think about like actual clinical evaluation, because acne happens in adolescence, like it's normal. Like as a teenager, the hormonal changes, you have these symptoms as part of normal adolescence. And since there is not health literacy that exists in all of the people, especially among adolescents, which means many individuals they do not recognize when there are symptoms that warrant clinical evaluation. Like they don't often go to the doctors with those symptoms because they think it's normal. And there is another gap in the healthcare pathway, like referrals and like under screening at primary care levels. Like if they go to the rural health clinic, like a primary healthcare center in one of the villages, they might not get diagnosed. Like they might not have they might not see what the patient is actually going through. Like there might be misdiagnosis, and there might be inconsistent diagnostic criteria application, and in some settings there might be stigma too that discourages seeking help. Like they think we don't need help because it's normal. It might go away by age or something. And from public health perspective, it is not just a delay, it is also like educational, structural, and systemic health level issue. And this gap also represents like missed opportunities for like early screening, prevention, and also like mental health support, like Dr. Mamtani has mentioned. And if we want to close this delay, we need to have stronger menstrual literacy programs that you guys are already doing by doing these amazing panels and like actually reaching out to populations, like going to schools and like educating students. I think that's where one gap we can fill the gap. Like that's one thing where we can fill the gap. And also like adolescent-centered reproductive health education, and also provider training. Like as I mentioned, like in medical schools, if we were taught like specifically like patient education, like reducing the like misdiagnosis and like actually listening to the patients and having time with the patients, like Dr. Prabhu has mentioned. We don't often do that with our patients, and that's where the gaps can reduce, like actually talking with the patients, going through their history and like the symptoms, and actually making them feel heard. And then that could lead to like an early diagnosis, and like we could talk treatment measures and like management measures that we could do. And in short, like epidemiology clearly tells us it's not just being missed because it is rare, it is being missed because our systems are like not designed to catch it early enough, is what I think.
Dr. Mamtani, I see you are listening very carefully to this discussion. So, like, I would really like to know what's going on in your mind, like, regarding this particular context. Like, if we say we want to link, let's say, depression or anxiety to PCOS, like, what would be the epidemiological standoff according to you?
Can you come again? What would be the?
Like, what would be the epidemiological point, like, that you think, like, in this case, like, how are they related?
Yeah, I mean, if I were, so basically we are, I can use a psychiatric term here. It's called treatment gap. Where, psychiatric epidemiology, we describe treatment gap as, someone has an illness and they don't seek treatment for it. So the kind of insights that that Dr. Tazeen, Dr. Akshay, and Dr. Sneha have been giving, I realize that, there is this element of stigma that's there. But if you were to, bring in the mental health angle here, that I think contributes to the fact that the help seeking is going to reduce further. If someone is, let's say, having depression or an anxiety disorder, very common. I see, people with certain body image issues that they come directly to my clinic from, let's say, a dermatologist who would have referred them to me because of some underlying depression that they would have seen. And that's when, I ask about, how, I mean, asking about menstrual cycles is a routine question for a psychiatrist. So, because it has a lot of other treatment implications. And that's when I realize, oh, this person actually has irregular cycles as well. And that's when I take the help of my gynecology colleagues. And later I realize that, okay, this person also has PCOS. So, the pathway to care can be very different, like Dr. Akshay also mentioned. But what matters here is that the help seeking should be improved. And at the end of it, I think I'm a very strong advocate for, mental well-being. So I would rather say that, if you were to improve the treatment outcomes, or, not even treatment outcomes, but the detection of PCOS, screen for mental health issues actively. And I think if you're able to do that, the detection can also improve. I hope that answers what you were looking for, Giri.
So, I think you mentioned, so what I understood is like you mentioned about the treatment gap.
Yeah.
So, like one of the questions that comes to my mind is like is over medicalization? Like, yeah, I think yeah, that's the term, over medicalization. Like, is that actually a real problem here? Like, are we getting too quick to like prescribe certain specific medication, let's say metformin, or like in some cases oral contraceptives, like without actually understanding what the stressor is?
Yeah, I think that's absolutely correct. Because, like Dr. Akshay also mentioned just a little while ago, that not every person with irregular cycles has PCOS. Now, this is another problem that, a lot of times people tend to have this, they catch this narrative, okay, so and so girl, she had irregular cycles, she's diagnosed with PCOS, and even I'm having irregular cycles. But no, that's not the case actually. And, when I think of it from a psychiatric hat, even stress can be a very significant contributor to irregular cycles. And nowadays the lifestyle is stressful. I mean, let us all accept that the kind of times that we are living in, times are changing. And I think my gynecology colleagues can throw more insight on that. But I believe the prevalence of irregular cycles in young girls is on the rise, and it has to do with a whole lot of factors. And stress is a very important contributor to that. But yeah, like you rightly said, we're kind of over medicalizing it, and lack of proper attention, lack of professional care. Uh, then we might rush into calling them PCOD. I don't think the mistake is happening at the end of the clinician. They are very wise enough to hold their medications back and advise medications at a very later stage, maybe if required. But I think the rush is at the patient's end. The patient, comes in. I mean, I can imagine that people would come into the gynecology OPDs, and the first statement that they would say is, Doctor, I think I have PCOS. Can you give me metformin? Because nowadays, in the era of Chat GPT and AI, they would have already Googled all of this, put that on Chat GPT, and they would have got that treatment. So that's not that. I'm assuming that's a very common thing that would have happened at the patient's end. But the people on the other side of the chair, they are very wise enough to understand that no, this is something that is primarily a lifestyle issue, and that should be something that should be addressed first.
Direct, just want to add to that and
Yes.
just summarize from my own experience. See, nowadays what happens is that irregular cycles are so deeply linked with PCOS that first and foremost, nobody understands the definition of an irregular cycle. In PCOS, you need to have consistent cycles which are delayed oligomenorrhea, which is more than 35 days. So many a times what people think is that they've been having a regular cycles of somewhere around 25 to 26, which in a month or in once or twice becomes 30 to 31 days. That immediately gets classified as irregular cycle, which is actually not the fact. That is the first point. That is where awareness comes in. Second point is that, as rightly mentioned, there are a lot of other factors which can affect the menstrual cycle, stress being one of them. And stress need not be any chronic stress at work or something. I have very commonly seen and very commonly observed in patient through experience that, for example, even if you're going, for example, just a person who's going for trekking, who's living in a normal plain land, who's going for trekking, might experience stress due to the weather and climate there, and that can impact the menstrual cycle. Or you have got a wedding coming up in your family, or you are going to attend somebody's wedding, you're doing a crash dieting for that, or you're having a sudden change of lifestyle that can impact your menses. Or you're shifting places for work. For example, you're relocating from Bangalore to Delhi, and there is a sudden change of a lot of things happening. Even that can impact your menses. Fourth, you're doing a crash exercises, fasting, doing some kind of intermittent fasting along with crash diet exercises that can also impact your menses. So stress in any form can affect your menses, and one of thing does not need to be characterized as PCOS. This is something what the patient needs to understand loud and clear. And secondly, as you said, clinicians are wise. Yes, clinicians are wise, but clinicians under pressure also sometimes give up, because when the patient consistently keeps harassing you saying, I have got PCOS, I've got PCOS, prescribe something for me. So some people, due to the fear of losing patients, also do prescribe something for them. So that is also a fact. And when you come to over medicalization, one thing you need to stress upon is that, see, when sometimes PCOS patients come to me, and when I counsel them and treat them and see, try this for 2 to 3 months and then come back. So first question is, aren't you prescribing anything for me? So if you give them a blank prescription, if you don't give them anything, so first you need to make them understand, see, I'm trying to give you a lifestyle modification. If you're able to do that, well and good. We won't need medications for you. Try for 2, 3 months. If you're not able to do that, come back to me. We'll give you a medicine. Medicine is not treating the root cause. This is just an aid for you to transform into a normal or a proper lifestyle. So that kind of awareness has to be given to them before you prescribe medicine, not telling that this has got a wonder drug which is going to treat your PCOS. So these points, from my experience, need to be added on, just summarizing on what Dr. Mamtani has said very rightly.
So you mentioned like about the aerobic exercises, like also about the resistance exercises. So I think the aerobic exercises directly reduce the cortisol levels, which would improve the HPA axis. So like in today's time, like are we under prescribing this? Are we under prescribing aerobic exercises like as a, let's say, as a neurological intervention, like for the treatment of PCOS?
See, exercises, whether aerobic or anaerobic, both are required. One cannot solve the problem entirely. There is another stigma also in, I could say, at least about Indian women, that there is this thought process that if you do weight bearing exercise or if you go to the gym, you're going to develop a muscular body. Even though the thought process is changing in Gen Z now, a lot of people are flexing their muscles, but still that stigma is there that you'll become a masculine figure if you go into weight training exercises, which is absolutely wrong. Even men cannot get a masculine or a flexing figure in spite of working in the gym for a very long time. So females are not going to develop such a figure very soon. So that kind of awareness has to be given, because muscle strength and muscle mass is required for insulin to act properly. It directly impacts your bone health also. Aerobic exercises, yes, it's very essential because it is going to bring down your consumption of calories, is going to increase. It's going to bring down your fat level. It definitely, aerobic and anaerobic both can bring down your cortisol level, because both are going to reduce your stress. The exercise component, much more, because people find dieting very easy. There are a lot of crash diets available, and people feel fasting and dieting is the best way to lose weight. In that matter, even if you just fast for one day, or even if you don't take water for an entire day, or even if you take Lasix tablet, which is a diuretic, that can directly reduce your weight by 1 to 2 kg. But that is an unhealthy weight loss. That is not a good weight loss. So even when you do these exercises, especially the weight bearing exercises, your weight might increase initially, which is a good sign because your bone strength and muscle mass is increasing and your fat is decreasing. So healthy weight is increasing and unhealthy weight is decreasing. So these kind of things you need to go into depth and make them understand, only then they're going to follow it.
Dr. Tazeen, what's your perspective on this?
So, as Dr. Akshay actually has rightly said, basically, as we all are talking, that we have to treat all the causes which are there. So, basically, it is not that you are over prescribing. It is very difficult for me as well, and I have experienced it in my clinical practice as well. When you will just say that lifestyle, your patient won't ever follow up with you again. They won't come back. That who is this doctor just telling me that go and reduce weight, and that's all. And the other thing is that I'm asking her that you have to go to gym, you have to do the exercises, and you have to reduce weight. I need to find out that she might be having some eating problems, she might be having some other problems which are actually not treated, and by the end she is not able to reduce weight. And most of the patients, basically for a female, when you directly say that this is lifestyle, you have to cut down your weight, that is very difficult to absorb nicely as well. Okay, so basically whenever I talk with a patient with PCOS, actually that only you can do in your private practice. When we used to work in government setups here in Pakistan, the situation is more or less same, just like India. In government setups, you have 2-3 minutes for one patient. You have a large number of patients. You can't counsel your patients, you can't spend time with your patients. So here basically whenever the young girls, I do this clinic, sub-fertility clinic, every Monday. Specifically these young girls, they are coming to me, and I just tell them, you can say my opening statement is, this happens in this life, this can happen. You should not be ashamed of, you should not be worried that why. Actually, as we discussed, it is very difficult for a young school going girl to come to a gynecologist. The first thing is that they reach gynecologist very late. The other thing which actually we face is that you can say a tool in PCOS for menstrual regularity is oral contraceptive pills. Then you have to counsel their mom, sister, aunt, everyone, that why you are giving oral contraceptive pills to a young girl. Like they will search, they will Google, they will do chat GPT, and then that is the question, that why these medications, why this specific medicine you are going to give to my girl. So that is another aspect. So all these things basically, as we all are seeing, that is not a one problem which we have to treat, that is a set of problems which we have to actually manage. Medication is important until and unless her symptoms are not resolved. Meanwhile she is coming back to her lifestyle, then the patient's satisfaction is also not there. So we have to start both at the same time. Lifestyle advices, then medical treatment is also very important. What actually is their problem? At times patients, they are having menstrual irregularity might not be there. They come to you and then you find out. So you have to treat your patient, not one problem or the other problem. So that is the thing which we have to do.
So I could catch one thing, like which I think all of our panelists have mentioned, the treatment gap through AI. So I think Dr. Mamtani, Dr. Tazi, and Dr. Akshay, everyone has
Yes.
mentioned that. So in fact, Dr. Isha also mentioned that. So in fact, I being a personal advocate of digital AI, like digital health, like I've done some work on that. So like I want to ask one question, like Dr. Isha, like do you think can AI actually close that gap, like that one major gap in case of PCOD? Like in case of the Gen Z, like if you allow me to say, like the most, like if you allow me to say, like the one of the most stressed generation or the academically most pressured. So like let's say a chronically stressed generation. So like do you think will AI be able to close that gap? Uh, I think Dr. Isha is having some network issues. So, Dr. Tazeen, what would be sorry, Dr.
Actually,
Sneha. Yeah,
yes.
please, ma'am, proceed.
AI can help. I have seen my patients that they are, completely taking all the consultation from AI through voice chats. Then they coming to us and they even, seek advice that who is the best fertility expert in Lahore. Then they come to clinic and they say that I asked from ChatGPT, so that's why I came to you. So the things are basically AI can help you, but at the same time, it can't be correct. The clinical correlation which the doctor physically is doing, AI can't fill that gap. So when you are talking with patient, that is important. When you are examining your patient, that is important. When you are, listening to their concerns, that is important. So then you reach a diagnosis that is not solely based upon what at times the patient feels something that is the only mainstay main problem for them, but we are finding the other causes which are there which needs to be treated. So for the patient, that one problem is the cornerstone. For us, the other problems, until and unless we are treating those causes, we won't be able to fix that problem. So AI can help, but not, it can't be 100% perfect. And at the same time, you have to correlate the things. Clinical features, you have to correlate with biochemical features. You have to correlate with psychological impact. As I can see that there was one question in the chat box as well, that why the girls with PCOS, they always feel that they are emotionally exhausted. So basically, we have been discussing this, that menstrual irregularity, weight gain, body images, all these, they are going to have a psychological impact. So that's why they are mentally exhausted. They feel mentally exhausted. That is somehow knowingly or unknowingly that is affecting mental health. So that is basically important, which we need to look at. AI is good, but not for every advice. That you just have to talk with AI and then you have to meet your doctor.
Dr. Sneha, like from a public health standpoint, like are we actually equipped to meet like that stage?
AI can be good and AI can be bad. It depends on who uses it and how we use it for our own information to learn. AI can bridge misinformation and some conditions by making it, more reliable, sometimes evidence based. It all depends on how you ask, like what you ask for AI. Sometimes AI can give all positive information or whatever you need to hear. Um, that's where it can become messy. But sometimes if you have like particular specific questions and like you ask for evidence-based information, that's where AI can actually go through research papers and give you like evidence-based health information, which can be, a bit accessible and easier to understand for some people. It can simplify some complex medical concepts, clarify some myths that exist online, and and one thing I think it can help is like tracking symptoms, helping them tracking symptoms, like prepare like a notes or like a spreadsheet of tracking symptoms and like understanding few patterns and like prepare better questions, when they go to a healthcare provider, like what questions can they ask a healthcare provider, like what if what we read is true, and like the healthcare provider can actually tell if it's a fact or it's just a myth, it's a misinformation. It can help with that, but it can't be a replacement for like any medical advice or diagnosis. But it can be a supportive tool, maybe like to increase the literacy and like reduce confusion, in between appointments if you can't get an appointment. Yeah.
Today only, actually, I was going through a post over Instagram only, I think. It was either Instagram or LinkedIn only. Like, there was a post which mentioned that social media has been linked in multiple studies to heighten the cortisol and disrupt the sleep architecture. Then, like, do you think are we underestimating what a phone in young woman's hand can do, like, to her hormonal health?
for sure. Yeah.
Dr. Akshay, what would be your opinion on this?
First and foremost, regarding AI, I think AI is a very good tool and it should be as a tool only. So the best part is that what I have noticed in that, at least maybe 5 years back, when a patient walks into your OPD, there are certain complex terms you need to explain it to them. Most of them are not aware earlier. Now you don't have to start from the scratch. There is a certain kind of base which they already have in their mind. For example, mostly they get a scan report, they send it to ChatGPT. ChatGPT gives them an explanation, or any AI. Or they have a biopsy report, they send it to whatever AI model, and that gives a explanation. So they're already aware of what I'm going to say. I don't need to prep them for, okay, this might be cancer, so you might require this surgery, and then maybe extensive dissection and chemotherapy. They're already primed to that. That is one of the best things I've seen about people being very familiar with AI. Secondly, another good part is that when they submit the report to AI and when I submit the same report to AI, more or less I get the same answer. So I can also expect what they're going to ask me. So you can use AI also in the same way as a tool for yourself. Thirdly, the thing is that if you closely watch AI, you may be a better expert at it. AI never gives you a pinpoint or a definitive answer. Finally, the decision lies with you. If a 45-year-old female has a fibroid and she has got symptoms, just an example, AI will give you an array of things: what can be done, what needs to be done, what may be done. Finally, the decision has to be taken between the doctor and patient. That's what I feel. And even me being a surgeon, AI is not going to tell me which patient can be operated or what decision I need to take on the table. That has to come from the human itself. But AI will prep you for what all possibilities are there. Secondly, very good thing where AI comes in PCOS and all is that if a patient asks you, I saw a question in the chat box also, what are the foods which can be eaten, what calories has to be taken, what. So if you give your age, your weight, your kind of activity during the day and ask AI to make you a diet plan, that is more or less accurate.
Okay.
Now, you don't need your doctor to crack your brain, you don't need a dietitian or anything. More or less accurate diet plan and exercise plan will be given by AI. So these menial tasks can be done by AI very easily. And even if they ask you also, you can also prepare the same diet plan and give it to them as a printout. So AI has to be used as a very good tool. It's an aid for your practice, but you cannot completely depend on it. If you ask AI a question in two different ways, the opinion might differ. So you have to be cautious. Everything comes with it's a double-edged sword.
Yeah, actually, in the recent days, I was working on a paper, impact of AI. Actually, we were specifically using Claude, ChatGPT, and Gemini only, to check for the clinical reasoning score. So we actually employed machine learning and NLP for that to check how are the students responding to use of AI. At the end, we could also reach to this same conclusion. AI is something which is actually augmenting the conventional teaching styles. And since this was just for medical students, so we could also reach to the very same conclusion which Akshay sir just mentioned. So
Yeah, and again, you mentioned about the social media aspect. The social media aspect has really contributed to a lot of stress in the present generation, in every generation, because social media only portrays the best aspects of everybody's lives. Only the best and the cream aspects of lives are seen. So everybody wants to aspire for that, and that leaves people stressed. So just a counter question: why do you call yourself the chronically stressed generation? What is stressing you so much?
all the late nights that we are putting in,
We
for the
also had
last
late nights.
for the last three, just to say just a figure of speech, for the last 3 days I've been constantly awake, for the last week I just had a sleep of 3 hours because of the exams. Then this week, certain events and certain papers that I'm working on. So
Yeah.
yeah,
That
for
is not
that.
specific to your generation. That has been since our generation also.
For sure, say
Gynecologist.
I would add the societal expectations.
Okay.
Like
Good
that's
point,
You
one
have
ma'am.
part of
more,
it.
you
true.
have more social pressures, but let me tell you that when we were doing MBBS, I completed my MBBS in 2010. So you guys are able to make your assignments and things in 2 minutes using AI. We used to open all the big books. We used to do all these things, all those long efforts. And I feel that the pressure at that time was higher as compared to this. But you guys, you have various ways of having pressure, and then that social pressure, that the competitive environments and all these things, basically that is added a lot to your pressures.
True, ma'am. Like, yeah, fair, actually.
Society has never been less cruel. It always been. Dr. Mamtani might know better.
I was just waiting where this discussion is heading, but I think sir is actually right. The role of social media is immense, and I mean, even I mean, you slept for 3 hours. You're lucky before your exam. I remember going for my anatomy exam. Still remember that night very like I could not even sleep for 1 hour, but somehow managed to go there. But I think the social media has significantly played a role in the chronic stress in this generation as such, because the kind of expectations that have been set for a so-called normal life have been changed significantly. You secure rank one in, let's say, one of your exams, you will post that on social media, but the same day you probably met with an accident, your arms were bleeding like anything, but you chose not to put that. So you always paint a very rosy picture on social media, and the other person is only seeing that positive aspects. Just trying to elaborate on what Dr. Akshay was trying to convey. And so the other person are always living in, oh, this person has such a wonderful life, I don't think I have this good a life, my life is all bad. You know how they say the grass on the other side is always green, and this is how the social media is actually, spoiling the whole generation. Having said that, I think let's face it, we cannot live without social media in today's time. I mean, I think social media has also made our lives very easy. The very fact that you have 50 plus participants this late in the night, I'm sure social media has had a role to play in that. And the kind of initiatives that you're taking, social media definitely has a role to play. But more than anything else, I mean, coming back to the topic, I feel by virtue of its role in increasing the stress, social media can definitely contribute to increased rates of PCOD. I'm not sure. The other panelists can tell me if there has been any study on the prevalence of PCOD, let's say 20, 30 years back versus the prevalence now. I'm assuming it would be on the rise. One, because of increased awareness, but also because of these other factors. I think that is something which is worth exploring, if not done yet.
Dr. Thasin, like, what would be your perspective? Like, if you compare the, like, about 10 to 20 years back perspective with the current trend?
It has markedly increased basically in the recent years, because our lifestyles have also changed a lot. So basically sedentary lifestyles and, sleep deprivation and other problems are there. So it has increased markedly now in the recent years as compared to the previous years.
So, yeah, like Dr. Sneha, like from a public health standpoint.
Yes, I think it has been changed. And I also wanted to add, in social media, there are a lot of factors that affect, the stress. It's not just I mean, the misinformation is another part. It's also the body image, or how to live your life, like the nutrition. There are a lot of factors that we see in social media. You think you have to just eat like this, but it differs for different people. But you think this is an actual lifestyle that you want to be in, have a big house, have pets, and have babies, and you know um, eat like this, and you have to go exercise specifically like this. And but it can differ for different people. And also the positive things that we post, that there are a lot of negative stuff that happens in life and that we don't see. But all you think is you can only be happy. That's the only thing that can positively impact your life. But there are a lot of emotions that you have to deal with that we don't talk about in social media, and that also affects our life. um, I don't know where I'm going, but I was still stuck there in the social media part.
Okay, so just to come back to our topic, like this is something which I used AI only for. So I got one of the meta-analysis from Claude only. Like it said that a meta-analysis which was published in Psychoneuroendocrinology. It found that the women with PCODs are 3 times more likely to report the symptoms of anxiety, stress, or depression than the age-matched controls. So like it raised a question in my mind, like are we treating a hormonal disorder or like or a stress disorder, or like does it really matter like uh which came first, or like was it the stress part, or was it the therapeutic intervention, like how, like Dr. Mamtani, what would be your perspective, like point of view?
I think Dr. Momtani has taken a break, so I just fill in. See,
Okay.
basically, it's always a hen and egg situation. You really can't pinpoint because, see, by the time PCOS became prevalent of recent times, the diagnostic capacity has definitely increased, plus the awareness has also increased, plus the stress has increased. So you'll never be able to pinpoint in these diseases which came first, but definitely it's always a vicious cycle. Stress is adding to more PCOS, PCOS is adding to more stress, and it keeps on rolling. The ball keeps on rolling.
True, sir. Dr.
I'm
Tazeen,
so
what would be?
sorry. I'm so sorry, Girik. I think I missed a question. I was attending to something.
No way, sir. So, like, I just asked, like, I just went through a line and, like, I used the Claude only, like, AI for this. So, like, there was a study which was published in the Neuroendocrinology Journal, that women with PCOD are 3 times more likely to report symptoms of anxiety and stress than the age-matched control. So I just wanted to know your perspective as well. Like, does it really matter? Like, which came first? Was it the PCOD or was it the stress? Or like, what are we actually treating in this case? Is it a hormonal disorder or is it a stress disorder? Like,
Hmm.
what would be your point of view?
I'm sorry you had to repeat the whole thing again. It sounds like a detailed question. It was. But anyway, I think that's a very good insight, and it brings me back to something that I already mentioned in my narrative, that PCOD and mental health share a bidirectional relationship. So it does not really matter, but what matters is the kind of care that you're going to provide to this patient. So someone who has both symptoms of anxiety as well as menstrual irregularities, like I mentioned earlier, if you're just trying to give them metformin, that's not going to be enough, or OCPs, it's not going to be enough. You need to address their mental health issues also, so that you're treating the person holistically, and that is what I think is the thing. I mean, to me, I think it's just the same chicken and egg kind of a story, that murgi pehle aaye ki anda, but that does not make a lot of sense. What matters is how you treat it, and this meta-analysis just goes to show that what I just mentioned about the bidirectional relationship. So that should be the take-home message for everybody out here.
So, like, if you're looking from a perspective of the CBT, then like, what would be the therapeutic intervention look like in this case?
So, CBT, I think in this case, I think we're talking of a meta-analysis. So it's a large number of patients, but in PCOD in general, I think there are so we call them cognitive distortions. Faulty thought processes that we look at, and the common faulty thought processes that can contribute to the pathology in PCOD. One would be about the body image issues that has been spoken about extensively right from the first speaker. So that's something that is very commonly seen. So, building more insight about these body image issues, how they are, very well explained biologically, and how they can be taken care of, how that can be taken in a healthier way. That's something, that bit of insight building will help a lot. Apart from this, I think when, it's a condition like PCOD or PCOS, which is like a recurring kind of a thing, it's not like, you take an antibiotic, the bacteria is gone, and you won't get that again. It's something that you go back to your older lifestyle, which is obviously more comfortable, you get that again. And that kind of puts you in a state of helplessness or hopelessness in many cases. So this is another important area from a psychiatric, from a psychological perspective that, I would want to address. Just trying to build that hope that, how they can be brought back into the whole treatment process. Because, if the person gets hopeless, they stop maybe following all the lifestyle modifications. This is going to come back again. So that again forms a very important part of the treatment, I feel.
Okay, like my next question would actually be to Dr. Tazeen. So, the 2023 ESHA guidelines on PCOD explicitly recommended that lifestyle intervention and psychological support as the first line of treatment. But in still several cases, we can see that the pharmacological aspect is something like doctors are still opting as a first line treatment. So, like why is there this gap still like between in the current scenario between why are the doctors still not going according to the guidelines? Like what would be your take on this?
Basically, Girik, it might be a problem in some of the cases, but for doctors who are treating PCOS, that is actually very clear that lifestyle modification is the first line. So this ISHRE guideline is 2023. Before that, there was Green Top guideline by RCOG, Royal College of Obstetricians and Gynecologists, UK. That was first published in 2016 and that was updated later. Basically, lifestyle modification is coming from there. Like this has been the mainstay of treatment and first line treatment. At times, basically, pharmacological treatment is keeping in view of the patient's symptoms, that they want a quick solution of their symptoms, as well as they need a pharmacological treatment as well, until and unless they are coming to lifestyle changes. So basically, that might be a practice in some of the cases, but qualified professionals who are treating PCOS lifestyle, it is always advised first. But pharmacological management at times, it is, part and parcel of the, reversing their symptoms and regulating their cycle, or treating their symptoms, or until and unless they will come back to the lifestyle, their symptoms will be resolved, and after that it would be, physiological resolution of symptoms. That is how basically every professional is treating it, and I am sure that whether you talk about India, Pakistan, or anywhere, the consultants or professionals, they are treating PCOS in that way. There was another question in the chat box. I was going through the chat box questions, that a girl who is relocating and then she is having amenorrhea of 3 months, then again due to some other problems, there is, you can say that 3 months there is no menstruation. So how it can be find out that this is normal or not normal? See, menstrual cycle should be regular. If someone is having some amenorrhea spells or it is not regular, then the first thing, as we always have already concluded, that we should try to find out root cause, as every time that is not PCOS. And if it is PCOS and then amenorrheic spells are there, we always say that every 3 months, if there is no physiological bleeding or if there is no menstruation, then we can give withdrawal bleeding as well. Okay, so but that endometrium has to shed. Otherwise, why we say that there are long-term complications, that if that endometrium is not being shed, that will lead to hyperplasia, and in the long run, that is a risk factor for endometrial cancer as well. So if there is no menstruation, you are going with lifestyle modifications, that will take time. Definitely that will take time. Then every 3 months menstruation should be there, if not physiologically, by withdrawal bleed.
Dr. Akshay, what would be your take on this? Like would you like to weigh in on this?
No, that's absolutely the way I think most of the gynecologists practice, the way we have been taught. So, when you are suffering from PCOS or you are trying to get into a lifestyle modification, one important thing to tell them is that you may not bleed every single month. It may take time to have regular menses, but then you don't have to be worried about not bleeding every single month. At least once in 3 months, if you can have a bleed, as Dr. Tazeen said very correctly, it may not be a physiological bleeding. You might have to induce withdrawal bleeding also. So that is perfectly how it works everywhere, and that's the dictum you need to tell the patients. You need not be very much focused on having periods every single month. The purpose of having this menses is to shed the endometrium basically, so that it doesn't build up to a level of a hyperplasia.
Uh, Also one more thing, like just I think it would be a follow-up of this only. Like Doctor, you have started laparoscopic training programs, which speak more or less to the surgical capacity building. So, but when it comes to PCOD, most of the time what needs to happen is upstream of the operation theaters or the OTs. So how do you think like the role of gynecologist would come in like the mental health conversation in this aspect?
So that's what I initially started out with. What my first bit of talk was that, see, nowadays we are going into micro specialization. So I won't be able to do justice to a patient who is having PCOS because you need to spend a lot of time with that. So nowadays it's better that people, like for example, a fertility specialist or a endocrine specialist, gynec endocrine specialist deals with it, not in person, maybe having a team developed for the same, because you might require a counselor in the team, you might require a psychologist, you might require a dietitian in the team, you might even require an exercise specialist in the team. So there are a lot of people doing it this way as a teamwork, because that amount of time and energy focus is required for the patient to recover from her condition. So that is what would be required in today's date. There are certain diseases which have developed at such a massive scale. One is PCOS, one is endometriosis, which has come in a very big way. Another is fertility. So these issues require a specific dedicated team to cater to the needs of the patient.
Alright, I do have some more follow-up questions, but I think the audience has some really, really amazing questions in the chat box. So I think we can move forward with the audience Q&A round now. So one of the questions that I could see by Shruti was, imagine a 13 or 14-year-old girl walking into the completely new phase of the life. Welcome to the adult womanhood, which most of the girls would have been told. Like even the idea of menarche can feel overwhelming, confusing. Now imagine being told she needs to see doctors from multiple specialties. To her, that could feel frightening rather than reassuring. Sometimes, before anything else, what needs most is comfort, patience, and someone who makes her feel safe in her own body. Like Dr. Mamtani, what would be your take on this?
I really, and also I really like the empathy that has come up in that question. I could really see that. I totally agree. I mean, that's a very overwhelming phase for any young girl. Uh, PCOS comes later, but menarche comes first, and that itself, triggers a lot of anxiety. And that's where I think having micro specialists, as Dr. Akshay would call it, comes up under one roof with one person. If everything that can be addressed, that would be a great thing. You go to a busy person, and they're more likely to refer you to someone else. So I mean, I'm not sure, Dr. Akshay, how much does it translate in real life? Because here in Nagpur, which is like a tier 2 city, I don't find any PCOD specialists here, at least. But I think that's something that's need of the hour for cases like these. And yes, an emerging thing for all young medicos out there, because if you have that niche carved for yourself, you build a niche for yourself, and at the same time, you make life for your patients also easier if you're able to understand these nitty-gritties of the basics of psychology. You need not refer to a psychiatrist for that. So if you have those good counseling skills, good conversational skills, and let's not bring the counseling thing there, but even if you're good at conversations, I think you can do a lot of justice to that young girl who's there for help, and you need not refer all of them to a psychiatrist.
Susan. So moving on to the next question, by Priya. Uh, why do people with PCOS feel emotionally exhausted even after they appear physically healthy? Why is brain fog common in PCOS and how to overcome it? I think it can be an open panel question.
Let me just start on that. So I did mention about the insulin resistance, how that causes dysregulation in the way your brain utilizes the glucose. So, the way you consume and the way you are kind of using your energy resources gets dysregulated. And that's a very common reason. So it's essentially, to answer that in two words, that would be insulin resistance. Insulin resistance is actually contributing to that by various pathways, that can involve. I had mentioned about GABA glutamate, so that's a very common mechanism through which this can be caused. And also, there's this role of inflammation that we discussed. So, to answer it very technically, this is how the biology would, cause that brain fog. I'll be happy to hear what the other panelists have to say about this.
Dr. Tazeen, uh, would you like to weigh on this?
See, I again
Uh,
feel it's basically a vicious cycle which is developing. So, um, physical health need not always translate into mental health or being emotionally well-being. So, physically you might appear healthy, but emotionally you might not be, because there is a lot, as we have all discussed throughout the panel discussion, there is a lot of emotional stigma which is associated with it. So, again, there also comes in the importance of social media. As we have said, we see a lot of influencers very happy on social media, but in their real lives they may not be really happy. You see a lot of suicides happening, very famous and very influential people having a suicide in spite of having millions and billions in their account. So it's always not necessary that physical health translate directly to emotional well-being. They are two different pillars, and it can act as a vicious cycle, especially in PCOS, when because you're fighting a, what do you say, a sea of hormones, a sea of emotions, when you're trying to lead a normal life with so much stigma around, even from your family members, relatives, neighbors, your peers. There can be a lot of emotional issues which is going on in the background, and where there is a lot of stigma associated with you approaching a psychologist, not even a psychiatrist. Psychiatrist is a very bigger this thing. So a psychologist, even that itself brands you as somebody having some mental issues. So when there are a lot of things, there is no outlet to it, and you open the social media, which is the most easily accessible, where everybody is happy, where everybody is size zero, very rich and happy, you're definitely bound to go through these issues. Brain fog in specific, I'm not very sure about PCOS people having brain fog, whether it's a personal experience or I'm not able to see it as a generalized experience with people having brain fog in PCOS.
But I mean, I think I have read it's something which is described in PCOS, especially. Yeah.
Maybe.
I think that really answered that question. Uh, the next question from our audience is, I think this is for Dr. Sneha. Is there a country or a healthcare system that is genuinely doing well, and what can India learn from it?
I don't think there is like a single healthcare system that has solved PCOD perfectly, but there are like some countries who are doing better in specific areas around menstrual health. Like I have seen UK that has done like integrated women's health and like multidisciplinary care that they have. And also like Australia too, I think has like a PCOS guideline framework that has been influential. Um, I mean, India already does a lot, and there are like specific gaps, but there are few principles that we can adopt, I think, like integrating menstrual health literacy earlier in schools, especially, and strengthening our primary care screening pathways, normalizing mental health as part of PCOD management, because mental health is also kind of stigmatized in our culture, I believe. And reducing stigma through public health education, basically. That's the easiest and most effective way I think we could do. Um, and using digital health platforms like for awareness, like the things you're already doing, like with your social media pages, like you are creating awareness and education. I think that's one other platform that we could leverage for the information too.
That was quite an explanatory answer. Next, I think we have, how can a premenstrual girl prevent the onset of PCOS?
I think Dr. Tazeen has already answered that on chat. By
Uh,
maintaining a
okay, yeah, by maintaining a healthy. Sorry, yeah.
prevention
So,
is always good.
pe-
You need to make the parents aware also, because there is a emotional thing at a very young age that whatever the kids ask for, it's usually given. So it's usually high calorie chocolates, high calorie junk foods, and nowadays the physical activity is very less. So that all lays in the root for developing PCOS later. And somebody asked about a question about a girl having menarche at 13 to 14 years and facing emotional issues. I just want to correct, most of the patients who come to our OPD are having a menarche at 9 to 10 years of age now. So they are not even physically or mentally mature to handle or face that menarche. So the right age for menstrual awareness or counseling should be at around, I would say, 8 to 9 years now, because anybody can have a menses even at 9 to 10 years. You cannot wait to 12 to 13 years. 9-year-old is a third standard kid who is going to have menses. Just imagine.
So I think there can be a follow-up question like in the chat box. Someone has mentioned, is there such PCOS symptoms due to addiction or the treatment given, like which has affected it? Yeah.
That's a very vague question. If Dr. Mamtani can make any contribution to that, I would be happy.
So does the person intend to ask that is there any evidence of any addiction leading to PCOS?
Yeah. Or any treatment given that is affecting it.
So there are certain psychiatric drugs which can contribute to irregular cycles, or certain drugs which can cause, insulin resistance. But directly leading to PCOS, I don't think there are any psychiatric meds that can do that. And the same holds good for addictions as well. There's no psychotropic substance, be it alcohol, nicotine, which can, at least in my awareness, that they can directly cause PCOS. But yes, these are things which can contribute to oxidative damage, inflammation, and they can be contributing factors for PCOS. So I feel it's best to abstain from these substances.
And also I think we got one interesting question, like why do some patients with mild PCOS symptoms experience severe psychological distress while others do not?
Okay, so I mean, I think to answer that, it's a very complex thing, and we need to look at other factors that might be weighing in there. It's just that to put it very simply, they might be just a little more sensitive as a personality type to be having mental health symptoms in that sense. It's not really the PCOS. PCOS might just be a contributing factor, but there might be other aspects to their personality or to their how I would refer to the biopsychosocial model again. So the factors in their social life or their psychology, personality that might be contributing to that.
Dr. Sneha, what would be your take on this?
Every patient is different. Everybody has a different tolerance level. You can have averages, but you cannot generalize things. So some people with minor issues may exhibit a lot of emotional, for example, pain tolerance. Pain tolerance is not same in everybody. In spite of doing surgery for 10 patients with the same technique, same incisions, everything, some patients might have need for so much of analgesia, so much of less tolerance to pain. So that can happen, but you cannot generalize it.
Right.
I think we do have a lot of questions, but I think we are all on a bit of a time limit.
Yeah.
I think Dr. Isha couldn't join us today because of certain commitments. Uh, but I think still it was a truly, truly, truly enriching session. And like I would like to add one line. Like I got six mind. Like I'm sorry, four minds, one conversation. I think it was all collectively done. Like we all could learn something useful tonight. To the audience, like I would like to add one line. You can send if you have any other questions. You can also send us. You can message us in the group. We will connect you with the professors, or we will send it out to the doctors and the professors, and we can hear back from them. I'm sorry. I think Pratik has one more question. Uh, Dr. Akshay, like as you mentioned that some girls are getting menses even at the age of 9 or 10. So what's the ratio that such women get PCOS?
I don't have clear offhand statistics with me to say like if you have an early menarche, you're going to have a ratio of PCOS at such a higher this thing. I don't have clear statistics with me.
Okay.
They're likely they're prone to many problems in their life compared to people who are having menarche at 13 to 14 years of age. Because what decides uterine problems is the amount of exposure of estrogen to the uterus, which is there in a person's lifetime. So early menarche and late menopause are always indicators of poor health of the uterus, and it is predisposing to cancers of the uterus also.
I think that answered your question, Pratik. Right. So before handing over for the closing remarks to Raghav, I would just like to extend a sincere thanks to all our panelists on behalf of Games IRC. And like you all took your time out of your busy schedules, and literally it was an enriching session for us. And personally, like being again, as I mentioned, I'm an advocate of AI and digital health. So that was something which I personally liked the part in today's session. And exactly this, we could literally complete the entire circle of the topic that we were looking forward. So I would now hand over the mic to Raghav for the closing remarks. Over to you, Raghav.
I think everyone is enjoying the session, but due to some time constraint, we have to conclude this session. So, heartful thanks to all the doctors and participants for staying the course. I think we have 44 participants still right now. So, yeah, it was very engaging session. Thanks to Dr. Tazeen for immense help. When I messaged her, she even providing me the graphic designer. So she is very helpful. And Dr. Akshay, even being a very veterinarian doctor, he expected my invitation very fastly. And Dr. Sai, I think it's morning in the US, and she's joining the session. So thanks to her and Dr. Hari for bringing the psychiatric perspective and making the session so engaging. So all the doctors, your expertise has provided us with a much needed holistic roadmap for the patient care. And to all participants, thank you for active engagement and thought-provoking questions raised today. Your commitment to expanding your clinical knowledge is what makes the GAIMS initiative successful. A special mention must go to to GAIMS and IRC organizing team, Dr. Abhishek, Dr. Ishan, Dr. Shruti, Sujal, and Prashant sir, Isha, and many more. Uh, their timeless effort to being the scene from coordinating with speaker across the time zone to manage the technical logistic. For the certificate part, you will be receiving, all the participants will be receiving the e-certificate within your registered email. If you haven't given your mail, you can still give your mail on the form, and you will be receiving that e-certificate within 2 weeks. And stay connected. We have several more webinars and clinical workshop lined up for the 26-27 tenure. Please follow us on Instagram and also on LinkedIn. And this session is live on YouTube. So if anyone misses the session, they can also see that on the YouTube GAIMS official channel. So thanks.
Thank you, everyone. I think it was a great learning experience for me as well, personally. Thank you, Dr. Akshay, Dr. Tazeen, and Dr. Sneha.
Thank you.
so much, everyone.
Yeah.
Thank you.
Thank you so much, doctors.